Mrs. Smith is a 68-year-old woman with a history of heavy smoking who presents her primary care physician with cough and occasional hemoptysis. A chest CT scan identifies a lung nodule measuring 2.7 centimeters. The scan also reveals an enlarged lymph node in the right paratracheal area. The patient is referred to a pulmonologist who orders an FDG PET scan. The scan shows increased FDG uptake, both in the lung nodule in the left lower lobe and the lower right paratracheal lymph node. The pulmonologist considers the best approach for diagnosing and staging the patient's tumor at the same time. Per chest and NCCN lung cancer guidelines for patients like Mrs. Smith, whose imaging suggests metastasis, tissue sampling is recommended to confirm the diagnosis and clinical stage before choosing treatment. The pulmonologist decides to perform bronchoscopy with endobronchial ultrasound transbronchial needle aspiration, or EBUS-TBNA, of the mediastinal lymph nodes. During the procedure, the pulmonologist can see the enlarged right paratracheal lymph node and also notes a slight enlargement of the subcarinal lymph node. The next step is to systematically sample the lymph nodes, which involves starting with the highest stage node. The pulmonologist begins with the N3 node, which is the right paratracheal lymph node, then samples the N2 node, which is the subcarinal lymph node. Remembering guidelines from the College of American Pathologists, the pulmonologist aims for at least 3 and up to 5 needle passes for each sample taken. This will help ensure adequate tissue for ascertaining the tumor's histological type and conducting molecular marker testing for driver mutations. The cytopathologist assists in the process by performing a rapid on-site evaluation, or ROSE, on the tissues obtained. ROSE can help ensure collection of adequate material for diagnostic purposes and is helpful for determining whether additional sampling is necessary. ROSE can also help with making a preliminary diagnosis. Tumor tissue is collected to prepare a cell block, from which sections can be created for routine hematoxylin and eosin staining, immunohistochemical staining, and molecular testing as needed. If light microscopic analysis of cytology smears and cell block samples show clear evidence of squamous differentiation or adenocarcinoma, no further immunostaining is needed for subtyping. If it shows poorly differentiated non-small cell lung carcinoma, or NSCLC, subtyping typically involves use of limited immunohistochemical panels to detect markers, such as P40 or P63 for squamous cell carcinoma, TTF1 or napsin-A for adenocarcinoma, and chromogranin synaptophysin or CD56 for neuroendocrine differentiation or carcinoma. For all patients with NSCLC, next steps are PD-L1 immunohistochemical staining and, ideally, molecular testing. PD-L1 staining is recommended for all patients with metastatic NSCLC. Scoring can be performed quickly and is usually done in-house. Results are typically available within days. Molecular testing is recommended for eligible patients, for example, those with metastatic non-squamous NSCLC. But testing can be considered for metastatic squamous cell NSCLC. Many institutions send out testing, and results take time. In the past, single gene sequencing was common, but more recently, as the number of approved targeted therapies for specific biomarkers has increased, so has availability of larger multiplex assays for next-generation sequencing, or NGS. At a minimum, molecular testing is recommended for those mutations having FDA-approved targeted treatments, specifically sensitizing EGFR, ALK, ROS1, BRAF V600E, MET exon 14 skipping, RET, and NTRK 1, 2, and 3 mutations. Results are typically available within 2 to 4 weeks. The NCCN guidelines recommend that, when feasible, molecular testing be performed via a broad panel-based approach, most typically NGS. If such testing reveals no identifiable driver oncogenes, RNA-based NGS can be considered to maximize detection of fusion events. For Mrs. Smith, hematoxylin and eosin staining of a cell block section from the N3 node reveals poorly differentiated adenocarcinoma with irregularly spaced nuclei that are variable in size. The sample from the subcarinal N2 lymph node was negative. Immunohistochemistry using TTF1 confirms the histology is adenocarcinoma. Immunohistochemical staining for PDL1 reveals the tumor to be 100% PDL1 positive. Imaging plus pathology shows that Mrs. Smith has metastatic PDL1 high adenocarcinoma, for which surgery would not be recommended. Molecular testing is ordered. The report comes back 3 weeks later, revealing an ALK rearrangement. This information is critical to deciding on a targeted treatment. Targeted agents with clinical activity against ALK include alectinib, brigatinib, ceritinib, crizotinib, and lorlatinib. All are recommended as first-line monotherapy in eligible patients. Alectinib, brigatinib, or lorlatinib are preferred. With the advent of immunotherapy and personalized treatment based on driver mutations, it's no longer enough to simply know the type of lung cancer. Collecting adequate tissue is crucial for providing the full picture and guiding treatment based on cancer stage and biology. The process should be viewed as an integrated whole. Diagnostic strategy is inextricably interlinked with staging and treatment, so decision-making must take into account all of these elements from the outset.